we got an overview here, a little bit of history and structure, some services, and so on. So we've got the Social Security Act creating Medicaid, and of course you also had Medicare. And one thing that the big kind of striking difference, and this a lot of differences flow from this original sin or original difference, is that Medicare is it's a federally funded program. Now, Medicare managed care, of course, those plans do get administered by private organizations and so on, but it's a fully federally kind of funded and largely federally administered program until you get down again to the individual plans in Part C or something. With Medicaid, from the get-go, it's a joint state and federal program. So there are federal and state dollars mixed in, and because states have a stake in this, they can set a lot of policy decisions themselves, which of course then means that rather than politics on the federal level or policy on the federal level or the presidential administration or the legislature on a federal level being the one who sets all policy, in Medicaid you've got that happening at the federal level, but you've also got that happening in every single state. And so there is this kind of constant interplay, and that adds a constant level of kind of if not uncertainty, at least variability and complexity as you look across eligibility groups, states, point in time, and all the other factors that you could think of. So there is some flexibility granted by the federal government, but then the state administers the program, which again is just there's a very big difference from that to a fully federally funded and largely federally administered program. We've got a link for the full act there as well. So as we mentioned, there are some basic rules on eligibility and benefits. There are some mandatory requirements, but states in administering the program are going to make a lot of choices. There are optional covered services. And when I say states make choices, they can make choices about quite a few things in terms of how they administer that program, even if you've got these guaranteed benefits or kind of core benefits of the Medicaid program. So there is a lot of variability in how that gets administered. And that may be relevant for how you decide to analyze your data if you're looking state to state. And then you got payment levels. And again, there are state and federal dollars. And I think we're getting to that in this next slide. So the FMAP, this is the federal medical assistance percentage, is kind of the percentage of the Medicaid program in a given state that is accounted for by federal dollars. So federal spending in a state can range from 50% up to about 3/4, a little more. So what you would see in some states is that Minnesota or California and some of these other states where you've got a 50% or so, that's a half and half. So that means like every dollar that's spent by a state, for every dollar that's spent by a state, the federal government puts in a dollar. Meanwhile, you've got other states where you can look across any of the darker colored states, Arizona all the way stretching over to Alabama or South Carolina or Kentucky. You've got states where for every dollar the state spends, the federal government might spend $3. So the share of Medicaid spending is much greater in certain states, and the number one reason for that is to adjust for income differences. So at least I'm not an FMAP expert, but I do believe I know that the primary factor in that FMAP in the FMAP, that is the percentage that we're talking about, the calculation of that is per capita income. And so this is an income adjustment. It's a way of making the the federal spending, if you want to understand it this way, a little more progressive in its administration. This is one way that the program tries to account for this, which makes sense because Medicaid is primarily designed as kind of a safety net, to use that term loosely, kind of a safety net program. And of course, if you're going to do that, we need to be pretty cognizant of income levels. And so we do see this percentage as kind of an underlying difference in the way that states experience this. The other way to think about this is not just federal support, but it also in some ways is an incentive to get certain states to, or it can act as an incentive to get certain states to spend more dollars on Medicaid. And by that we mean that if your state knows that, hey, if we spend $1, we're going to get $4 total, when then that might incentivize the state to spend a little more on some of its populations that otherwise might be underserved. Maybe they can reach them through the Medicaid program doing that. So on the one hand, it is the literally the share of spending by the federal government, but you could also understand it potential, and it's meant to adjust for income differences in particular. But you could also understand it as in some ways, an incentive for states to spend on those populations covered by the Medicaid program. I would say that this is something where, if you're looking at spending, this might be relevant in your study. At the same time, you want to be thinking about this if you're looking at state differences and so on. But it's again kind of a piece of contextual information that you want to bring in. One of the considerations you want to bring in among many as you're formulating a study. So this may or may not be relevant to the question that you're asking. It may be such a fairly high policy level that if you're a clinical outcomes researcher or something and you're looking at how policy plays out on the ground, this may not make a huge difference to you, but it's certainly something to be aware of, and it may be relevant as you're thinking about this study design. So again, especially if you're looking across states or potentially across time if the FMAP changes or something. We've got a lot of different policy things that have come up over time that have kind of shaped since the institution of the Medicaid program, going back to the Balanced Budget Act in 1997, which created CHIP. And I'm gonna be coming back to CHIP a few times. The main reason I would say is not because I'm a CHIP expert. I actually tend to the population I've studied the most in Medicaid has actually been low-income adults, especially the expansion population, and services designed to serve them. And so I'm not a CHIP expert, but the reason that I want to highlight CHIP is because it is really the primary other federal program that, again, I'll talk about in a second, is very similar in some ways, and very kind of interrelated and tangled up with Medicaid. But it's the one that shows up in the data. So in other words, you have to, if you're doing anything with both children as well as in some states, pregnant or birthing individuals, CHIP is going to be a relevant concern in terms of if you're looking at eligibility groups or if you're looking at what kinds of programs they're in or those kinds of things. CHIP is relevant in the data because it's actually there in the data. It's not uncomplicated. It is complicated a little bit in terms of figuring out how CHIP plays into the data, but this is the one other federal program as opposed to state or federal programs for, I don't know, food and cash assistance or some of the other programs that people might be on. This is the one where you really know it's going to be there in the data. And so we will come back to CHIP a few times, but I would say that we want to call that out as a big one. The next one is the MMA, the Medicare Modernization Act, which as the way it sticks in my mind is Part D. But the reason Part D is relevant for is because, as we'll talk about later, people on who are either older Medicaid or especially dual enrollees that we'll talk about in a bit, those people who are enrolled in Medicaid and Medicare, since Medicare is a primary payer for a lot of services, having a prescription drug benefit in Medicare, which there wasn't previously, can mean that a lot of prescription drug spending gets shifted to the Medicare program at that point. And so that's something to be aware of. It's something to think about, again, as you're designing your study. What are you going to do about duals? And we'll talk about duals more, but that's one of the ways in which putting a variable in for dual may not be sufficient in your design. We've got the ACA expanding Medicaid eligibility. Obviously, there's been a lot of research on that. And then we do have two newer ones that as we get into the data, you're going to be seeing these available in the data more, being the coronavirus related policy in terms of increases in the FMAP. So now if you weren't aware of the FMAP before, this is this one way in which that's the federal government could take action on that. Oops, sorry about that. So that's one way the federal government could take action on that, as well as maintaining eligibility requirements. And so that was kind of designed to kind of help keep people on Medicaid a little better. And there's been definitely some work on that as well in the empirical literature. And then we have a much more recent change just last year. This doesn't always happen in the world of policy, but it definitely, you see a lot of changes like this, especially in Medicaid. If you're used to looking at Medicare, this is a little different. You are going to see some policy changes that are a little more frequent. And so we had the Consolidated Appropriations Act, which ended that kind of continuous enrollment requirement in 2023, and I think you're probably aware of that. It hit mainstream news sources and things like that. It does still, keep continuous requirement enrollment for at least supposedly. Now, the reason I say that is because I've done research on some local administration of Medicaid programs, and sometimes people fall off the rolls when they shouldn't, at least from what I can tell in the data. So it makes me a little concerned. But it does have a 12-month continuous enrollment for children 18 and under, and postpartum birthing people. So that's just something to kind of keep in mind, that there have been these like very, very recent changes, and in terms of available data, we won't even see the last one yet in the data, I don't believe. So it's just something to kind of keep on the radar. But again, when you have these like fairly recent policy changes, but also fairly regular, pretty big impact policy changes that then play out so differently across states, there's a lot of things to understand, and a lot of changes to, if you want to use the language of some people, if you want to, a lot of changes to exploit in study design and things like that. CHIP, the Children's Health Insurance Program. So again, it's created in 1997. You got an enhanced FMAP, and you have state participation is optional, but all states are participating by 2000. Now, we have some sources, but they're easy to find. We'll try to share them as we go along. There are a few places where you can look that will show you how, the name of a state's CHIP program. There are places, because there's some interplay with the Medicaid program, as we'll see, some states will actually have Medicaid in the name of their CHIP program. So actually in Minnesota, Medicaid and CHIP are both called Minnesota Medicaid, I believe. Or I think New Hampshire, for instance, has Children's Medicaid is the name of their CHIP program. But a lot of states it'll be called, state name CHIP. And so you've got a lot of variation just even in how, kind of states name this, but certainly how they administer it. There are kind of three ways that you can understand Medicaid and CHIP and the interplay between these. Oh, and sorry, I should say, so CHIP, according to CMS, if you go to CMS and their materials, CHIP is kind of designed as a program where kids now, and this changes a little bit as Medicaid expansion played out and states made different kind of changes in policy. But CHIP, especially was kind of created at a time and is still relevant as a program where kids and their families, there may be too much income to qualify for a Medicaid program, but maybe not enough to qualify for maybe some state programs or other things. So in some ways, CHIP is at least partially a program that's kind of a gap filler in that way. And it's kind of used, so I guess if you want to think about the way to think about some of these other uses of CHIP, think about income levels and how they create eligibility thresholds and things like that. And think of CHIP as one more tool that states can use to address the fact that income eligibility levels may not reach everybody, and particularly kids or birthing parents. And so there's some flexibility in the program design, and this shows up in the data, by the way. So you'll see this in the data depending on which variable you look at, and I'll talk about that in a second. So you've got a few different ones. So one is, I've seen this described as Medicaid expansion CHIP, or it's kind of Medicaid CHIP. In other words, it's using CHIP as an expansion of Medicaid. And so this is an entitlement where it's meant to be full, fairly comprehensive in the way that Medicaid is. It's a similar benefit design to Medicaid. And so you've got CHIP as kind of using CHIP to expand Medicaid services in some ways. That's a gross generalization, but that's the way I think about it. The second one is separate CHIP. So you could also think of it as, you could say state CHIP, but they're all state CHIP programs. So it's separate CHIP programs, or S-CHIP. And there there's a lot more flexibility in benefit design. It's not designed or necessarily intended to kind of be offer those same kinds of comprehensive Medicaid benefits. And so there's going to be a lot more flexibility, but that separate CHIP will also show up separately in the data from the way that you would see CHIP programs. Or you have one where because of the Affordable Care Act provisions requiring Medicaid coverage of previously S-CHIP children. So previously you'd have kids who were just on an S-CHIP program. Now there's some requirements for getting them Medicaid services. So they have a more comprehensive entitlement package. And so you got a combination. And if you look at kind of graphs, or I should say, if you look at tables of state CHIP programs or state CHIP programs and how they interact with Medicaid, most of them, you're going to see combination. So most of the time, there's actually a combination in states, and they're going to use them in slightly different ways. And this is why me as I'm primarily more a healthcare delivery guy, so I want to be cautious about making too many very, very specific statements about all the ways that states can kind of organize their CHIP and Medicaid programs. But most of the time, I can say most of the time it's actually a combination. So an example would be like CHIP is used to expand Medicaid, right? So what we talk about, where CHIP is used as that Medicaid expansion to cover certain groups of children, especially around income. But then the S-CHIP program is further used to kind of either supplement or expand beyond that. So that you get kind of this interesting scaffolding where you've got the Medicaid program and then CHIP, and then CHIP and then S-CHIP, all within the same state. And so there's just most states, if you're looking at them. But I would say you probably want to understand, again, if you've got anybody who is birthing a birthing parent, or who is under 19 or under 21 in some cases, you're probably going to want to understand what's going on in those states as it relates to CHIP, if you're looking at those at younger populations in that state. Let's see. Before I go on, then, I just want to note a thing about how you would identify this in the data, and we don't have a great table for this, so I just want to kind of lay out some complications that show up with CHIP as it relates to kind of identifying it in the data. So on the one hand, you've got like a CHIP enrollment days variable. That's one way you could try to identify CHIP. The problem with that is that, to my understanding, I believe this is right, yeah. If you're using the CHIP enrollment days, that's going to show you enrollment days in an S-CHIP program. And so you're going to miss CHIP, which might be put under, Medicaid days. And so if you're just using that one variable, that is the CHIP enrollment days, you may be picking up S-CHIP. So know which variable you're looking at. On the other hand, there is one called CHIP enrollment latest. So you'll hear latest in the variable name. It's I think LTST it's underscore LTST is another variable. So CHIP enrollment latest is kind of latest enrollment in the year. Well, people can, obviously, even, in a lot of states, the combination is the most common way. So people may kind of change their CHIP status throughout the year. So looking just once also isn't going to give you the full picture of what was going on in the year for that person. And so whether you're using CHIP enrollment days, which has one issue, or whether you're using latest, which is kind of very snapshot, those are both, potentially problematic if you're trying to understand what happens during the year. So what we've run into is, very, very often, probably most of the time, we're looking at monthly indicators. And then if you're looking at monthly, there's the added wrinkle there. So looking at monthly basis, well, now you have to figure out, how am I going to roll these up? That is, how do I take many months, if I'm trying to say something about the year, how do I take many months and put them together? or maybe you're analyzing on a monthly basis. Because obviously things can change from month to month. So those are three different ways of kind of understanding how CHIP shows up in the data. I believe that's in the D&E file, which is kind of the primary denominator file for Medicaid that we'll talk about. You've got those enrollment days, which I believe indicates S-CHIP but not M-CHIP. You've got a latest variable, which again doesn't reflect what's happened throughout the year. And then you've got the monthly indicators, which I think are probably in some ways the most comprehensive and best look, but also require additional attention to how you're going to roll them up. And I'll leave that there. We're going to be talking a little more about other variables later, but I just wanted to make that note. Let's see. Just want to make sure we're doing okay on time. We also have dual eligible individuals. So dual eligible individuals we've got people who are older and disabled who qualified for Social Security disability insurance. So and by disabled, when I say that, it's important to remember that these are administrative categories. So that doesn't mean it's another person might not have some disablement that can be pretty serious. It's whether a person has been deemed disabled in through SSDI. So in other words, it's an administrative determination. Then we have people who are low income and older, and we want to think about, as you approach that, if you're used to thinking about duals, you've probably run into this, but if you're not, one thing to think about is, again, you have to do something about duals in your data almost always. Whether you're looking at Medicare or Medicaid, you need to think about what you're going to do with that, because it's a particular population and it's not just a random subset of either population. But when you're talking about Medicaid, one thing to think about is that you've got a couple of different categories. So on the one hand, you got somebody who was in Medicaid because of low income or some other status that led them to be in Medicaid, and then aged into Medicare. So you could understand it as Medicaid first duals. And if you were looking across multiple years and you had the right data, you could look at how that person flows from one program into both. Now that's a different pathway than Medicare first. So what might happen in Medicare first, as an example, is that somebody ages into the Medicare program, but their income levels or their asset levels are okay, and they are paying for healthcare as they do or long-term care as they do. And then at some point they have spent down. So spend down, that is spending down your resources, can lead them to moving from having just Medicare, older age eligible Medicare, to Medicare and Medicaid now needing to help cover some of their services. So those are two different groups, and they enter Medicaid and Medicare differently. They started differently, they enter it differently, they experience it differently, and so that may be something that you want to pay attention to in terms of how you'd identify things. So the main thing to kind of think about in duals is that in dual coverage, Medicare is a primary payer for most inpatient and outpatient services and prescription drugs. So in other words, most of the things that Medicare covers, it's the primary payer for in a dual population. So the first thing to say about that is that we've definitely done some looks among dual enrollees, and I would suggest that when you say primary payer, there is a thought that, hey, if Medicare is the primary payer and I want to study duals, can I just get the Medicare data? Like, do I need the Medicaid data if I'm looking at utilization, for instance? Maybe I'm interested in inpatient stays or something like that. Do I need the Medicaid data? And what I would say is that we have definitely found some we've found some permeable membrane around the idea that Medicare would necessarily identify everything without needing Medicaid information. In a lot of cases, you will see most, generally you will see most things if you're looking just at Medicare, but you may not see everything. And I hesitate to say whether that's because of a little bit of data messiness and administrative messiness that does show up in the data, or whether that's because there's some situation or scenario where Medicaid is picking up something and Medicare just didn't happen to cover it or hit it or something like that. That's a little bit of an open question. We've started doing some interesting research. So one thing that we found is that we were looking at how you apply algorithms to identify conditions. So when you identify conditions from administrative data, what you're using is the information, the diagnostic information, the diagnosis codes from claims, for instance, or encounter records that are submitted. And that's how you identify whether somebody has a condition in the administrative data. Well, Medicare has some pretty well-established algorithms for identifying those, and you can review those and see whether they actually fit your needs, because no one algorithm is always perfect for everybody. But the question still arises, well, if somebody has a condition, would I necessarily be able to always see that just from looking at the Medicare data? Or does the Medicaid, do the Medicaid data add any information? Do I see any new cases becoming positive because of the Medicaid information, the information that's in the Medicaid data? And the answer is yes. You won't be able to you won't be able to just identify something based on Medicare, and you will be adding some information to the identification of conditions, certainly. If you look at adding the information from Medicaid, that is, people will trigger the algorithm to a differing degree if you add Medicaid information. So Medicaid does add information. The degree to which that is the case is really going to depend on what you're trying to use it for. Are you looking at exposures or adjustment variables or outcomes, those kinds of things? I can say there's always a little bit of messiness in administrative data. Yeah, so something to keep in mind. Medicare is a primary payer. That doesn't mean that you can jettison Medicaid if you're just looking at duals. I would issue just a little caution with that until you've done a little checking. The other thing is that Medicaid participation varies by coverage level. So partials can include Medicare coverage of copayments and deductibles. The full duals, the non-Medicare covered services, you've got non-Medicare covered services such as prescription drugs pre-2006 and long-term care services. So you got somebody who is fully in Medicare and fully in Medicaid, including those like I said, long-term care coverage and those kinds of things. Whereas partial, you may get some help with the healthcare copayments and deductibles. And I would say there are several different programs that kind of relate to dual coverage or low-income coverage in Medicare. So we'll talk about these in a bit, but like the qualified Medicare beneficiaries, or QMBs or QIMBs, or specified low income, or the SLIMBs, some of those kinds of low income programs, those are not one-to-one match to these partial and full. So in other words, you'll get QIMBs or SLIMBs or some of these other low income programs. Some of them will be partial Medicaid participation, some will be full. So some will be partial duals, some will be full duals. And I think we've got a variable that looks at that later, but just keep in mind those are partial and full they overlap, but are not they're not determined by whether somebody's in a QMB or SLIMB or some of the other low income programs. All right, so one thing to add here. So this is from one of our looks. Now we're primarily using the DE file, which is the primary denominator file. This is kind of a preview of the data, so I don't want to spend too much time getting into the finer points of this. I want to use a data run to kind of make a general point, if that makes sense. So we have full dual and partial dual. As we mentioned, the full dual offering kind of the full Medicaid services, partial dual with the copays and so on. And this is rolled up from a lot of other information, but the full and partial is based on a dual status code variable. And then we've got total service records per member month and just member months of enrollment. right? So we're looking at, how many member months are we seeing in 2019 across these different categories, and then what are the total service records? And the total service records here, Medicaid data includes both fee-for-service and Medicaid managed care encounters. So there's claims and encounters depending on whether somebody's fee-for-service or managed care. We are putting those together for total service records, so that's where that number comes from. And I would also note that that's total service records, claims, and encounters across inpatient file, what we call the other therapy file, which is outpatient and all kinds of all the other healthcare type therapies you get, as well as long-term care and pharmacy files. So this is across basically all the claims files for Medicaid. That's where all these total service records are coming from. But there's this added wrinkle where things start exploding or expanding as you interact these different categories. Because in addition to full dual and partial dual, if you look along the left side, these things are also going to vary by the type of Medicare and the type of Medicaid somebody has. That may or may not be relevant to your question, but it's a potential consideration. So there is a combination of fee-for-service and managed care. Managed care, in most cases for Medicare and Medicaid, being kind of a capitated, per member per month type payment with risk sharing, that kind of thing. We'll talk about managed care in a bit. But you've got this combination where you could have Medicare fee-for-service and Medicaid fee-for-service. That does happen. But managed care penetration is pretty heavy across both programs and definitely in Medicaid. So if you're understanding Medicaid, you should understand Medicaid managed care. And so these big combinations of fee-for-service Medicare, but managed care Medicaid in a state. Or managed care, there is a very small number, it's an interesting way to think about it, of managed care Medicare, but fee-for-service Medicaid. And that has to, managed care in Medicaid has to, as we'll talk about, has to do with waivers and things at a state level. So this just means that somebody's got managed care Medicare, but maybe their state doesn't have that managed care option for Medicaid or something like that. But you've got 7 million member months there, so the relatively smallest category. And then you've got managed care, which is would have grown over time and is now a very big category. So if you think about it now, if we're trying to understand how many member months are covered and then how many service records per member month, kind of what is the kind of gross utilization that we're seeing, that varies not just by full and partial dual, but also if you're dual, you need to think about what type of program or what type of administration or financing you're in the Medicare and Medicaid programs. Are you managed care, fee-for-service, et cetera? And you can see there's actually some variation depending on which category you're looking at. It might mean that you want to remove some of the categories. It might mean you want to adjust for the category. But again, this is something from the data that's relevant to how you ask and answer your question. I think that's probably enough on that. We'll get more to managed care and some other things in a second. And Steph, I'm sorry, could you or somebody could you let me know how I'm doing on time? I don't have the agenda up because it's hard to see with the things. Is it?
Yep. This is scheduled to end at 10:15.
Yeah, I think okay. That's what I thought. I think we're on track. So covered services. Just to preface, generally there's fairly comprehensive package in Medicaid, which I think is really great especially in the states that have worked to do that. And you'll get different services that get covered by states at different times. A little while back, some of the people some of the faculty who work in my division had done a lot of work on doula coverage in Medicaid, and so that was something that was added in Minnesota. You just get state variations, and sometimes it's good news to see that a particular service is covered and those kinds of things. But there is kind of also a base kind of package in Medicaid, and then of course that's going to vary by. Are we talking about M-CHIP and S-CHIP for kids and all kinds of other things? So again, a lot of variation and a lot of kind of layers that you need to look at. So Medicare, if you're familiar with it, it's basically healthcare. Now you may hear, like my parents, they're on a Part C plan, and their Part C plan adds some additional services, and so you may hear you or a parent or a grandparent or whoever will encounter a Part C plan that's covering, vision or dental, or usually more often vision than dental. You'll see a program like that. And then of course you've got Part D where you've got some type of prescription drug coverage. And if you think about Part C, it can kind of cover that Part D benefit as well. So it may cover then that prescription drugs, may cover again vision or some other things that aren't normally covered under kind of the specifically healthcare definition, which I think is interesting. But so you'll see Part C and Part D kind of adding to that, but core Medicare is really healthcare. Medicaid is healthcare as above, and we'll talk about the specific services, but the big addition I would say is long-term care. Now, I have talked a lot about CHIP and children. The other thing I really want to highlight that really kind of characterizes Medicaid from my standpoint, beyond children and the policy variations that you can see and some of those kinds of things, is the fact that Medicaid covers long-term care, or a newer term being long-term services and supports. My wife's an LTSS researcher and social gerontologist, so I certainly have soaked up a lot of this through osmosis. But I would say that does make it very unique, because Medicare you will see, skilled nursing facilities and things like that in Medicare, but usually you're talking post-acute stays and some of those kinds of things. That's not for kind of long stay, long-term care. What you might think about as a typical nursing home long stay resident. That's the kind of thing that's going to be covered under Medicaid. And I'm going to say nursing homes for now, although I'm sure a lot of you know that Medicaid covers more than that, because core Medicaid is really geared toward nursing facilities. I can get into that a little bit more, but basically if you've got services outside of kind of the fairly institutional delivery of long-term care, you're probably talking about waivers, and that is not Medicaid proper. That's going to be much more state dependent. We'll get into waivers in just a second. So, but states can set the duration and scope and some of those kinds of things, even on required services. You've got other services that may be state optional. So, pharmacy and dental. Now that's going to depend. I believe that dental is required for parts of CHIP. So it may be state optional if you're talking about Medicaid, but if you're talking about CHIP, there's a little bit of a difference there. And then just to add that waivers and managed care kind of change the administration of the Medicaid program also. So there's a lot of different benefits. My takeaway here is that largely fairly comprehensive healthcare related services, as well as nursing facility type services. And that's from birth to, which again, Medicare is not usually going to be thinking about births as much, but when you've got, a quarter of the births in the United States covered under Medicaid, that's obviously a big part of the benefits that you'd want to consider. So a lot of healthcare related and long-term care type related, especially in facilities services. But again, especially if I could characterize the things that make this program particularly unique, it would be children and babies and birthing people, and on the other end, people in long-term care, as well as everybody in between. And then you've got a number of states. Then you've got a number of states starting. You've got some other specific kind of benefit packages that you can see that are states, quote unquote optional. And the way that states roll these out and manage them is again going to vary. But lots of different, PACE is an interesting program for all-inclusive care for the elderly. We've looked at that a little bit. Just kind of digging into how you track that in the data, some of these kinds of things. So there are a lot of states covering the benefit starting 2017, but again, just lots of additional potential services there. Then there are some restricted benefits. So I mentioned Quimby's and Slimby's, lower income and other programs that get Medicare premium and cost sharing assistance. So there's some help with those. Those, again, that overlaps with is not the same as full coverage or partial coverage as duals. The full and partial relate to the Medicaid benefits that they're getting, but SLMBs and QIMBYs could be full or partial. So it's not a clean overlap. You got and a number of other restricted benefits. I don't want to read all of these, but you can understand, emergency Medicaid, really narrow benefit packages for specific conditions, COVID, those kinds of things. So there are more restricted benefits where you get some Medicaid coverage, but it's for a much more limited scenario. All right, some notable features. So first of all, we got to highlight waivers. We're gonna mention waivers a lot. Certain parts of Social Security Act allow the Secretary of Health and Human Services to waive certain requirements. Now, by waiving requirements, that doesn't necessarily mean making things easier for enrollees. It can, in effect, make things tougher for enrollees. So, waiving requirements could be waiving aspects of eligibility, so that, in other words, you can place additional rules on eligibility. So it can make, so in other words, I just want to say waivers don't necessarily make things more expansive or more easily accessed. They can, in effect, limit access and eligibility in some ways too. So waivers go in both directions in terms of expansiveness and access, both, greater and lesser, as we'll look at in a second. They are subject to rules. They need to be quote unquote budget neutral, and then some other criteria. I think they need to have some reasoning for contributing to improved health. I would say that exactly how to meet those rules is probably pretty wide open, or at least can be argued out pretty effectively if you're starting with a waiver and can get, for instance, state legislative action or other things to make it happen. So there are subject to some rules, but and I should note, I really want to highlight the link down at the bottom. You really, if you're not an absolute Medicaid superhero, always good to keep updating yourself on what waivers are active in what states, and especially if you're putting a data request package together, make sure you know what you're getting. Waivers are a huge part of what a Medicaid program looks like in a state. So pay attention to that, and I just want to call that out. Two common waiver categories. I am excluding managed care because we're going to talk about managed care. We have section 1115 generally, and these are research and demonstration waivers, which means that you may be able to waive services or eligibility type. That could be, certain behavioral health services. It could be trying to add non-medical services like housing, but also they can create restrictions. So work requirements, which obviously made a lot of news and got a lot of policy attention, or the waiving of what we call retroactive coverage, which I'll talk about in a second. Those things are also part of this waiver set. But then you've also got these 1915 programs. And the reason why this is really relevant is that if you are in the space at all of long-term services and supports, as I mentioned, traditional Medicare, conventional Medicare, the core Medicare really is primarily, it's going to be oriented toward facilities and nursing homes. And what the 1915 waivers do is add a lot of action around home and community-based services. Now, if you're not familiar with HCBS, you might also think about things like assisted living, selecting your own care provider, possibly even housing for certain adults. So home and community-based services really expands the potential menu of long-term services and supports for people in the Medicaid program. So the 1915 waivers are really relevant to that. Now you've got a lot of different changes and things that can happen in waivers, but this is just kind of a look at how waivers might look if you were to look at, how many are approved versus pending. This was as of early August 2024. related to eligibility groups, and that's both expansions and restrictions, and as well as benefits. Are you expanding or are you restricting? And then things related to social determinants of health, like housing. Are there some provisions for that? So there's kind of a lot of different types of waivers, but you can kind of see there are a lot of waivers that are approved in almost all states. So that's again, big part of how the Medicaid program happens. Then this is just, if you were going to try to identify waivers, this is just kind of a quick look. So if you're trying to identify waivers, note, and we'll talk about this a little later, I just want to introduce the idea that TAF only goes back to about 2015, depending on the state. And then before that, we had MAX. So MAX, being the Medicaid Analytic Extract, was the older data submission and data files system in Medicaid data for CMS. So that used to be what we supported as ResDAC, was MAX. And TAF is new. And I have to put in a plug for TAF. It's not perfect, but I would say that the movement to TAF has opened so many avenues for potential research that I think were just kind of too hard to do and navigate in the MAX system. It's really kind of, I've read the literature on what CMS has done to improve data submission systems and all kinds of other things to transform that. And TAF actually goes back to T-MSIS, which is the transformed medical, so it's in the name, transformed. It's a truly transformed system, and I would say it's kind of a modern marvel of data engineering if you consider the scope of what has been done moving from MAX to TAF. It's a huge effort. But for researchers, you're looking at MAX files or you're looking at TAF files, and especially if you're looking, anything kind of expansion and pre-expansion around that time is also coinciding with change from MAX to TAF. And so there was a little bit of a transition period around that time. I think we've got some other information on that. But if you're trying to identify waivers, you've got both kind of the denominator type files. The only thing I would add is that especially if you're in TAF, that there is a supplement for waivers. There are a number of supplements for the D&E file in TAF. That is the main denominator file in TAF. There are a number of supplements, and one of them is for waivers. MAX, from 2005 to 2015, and really I don't think you're going to get much before 2005. Whereas, obviously the TAF is moving forward, and there was a little bit of, again, you're going to have to deal with a little bit of overlap in that changeover period. Now, waiver ID kind of existed in both types, but waiver ID is not the same thing as waiver number, because states were assigning waiver numbers, and under the MAX system, there wasn't any kind of harmonization of that to make that fit. And so you needed a crosswalk. So the crosswalk file is listed down at the bottom. So you needed the kind of crosswalk to make that work. I think we checked into that. I think we were able to make it work fairly well. But, when it comes to TAF, waiver ID, it should match waiver number, I believe. And so if you got state waivers list down there and so on, you should be able to actually do it a little bit more cleanly compared to the MAX files. But if you think about the pathway of linkage, you're thinking about the denominator file, the waiver information. You'll need some, probably some external information to track those waiver numbers and so on, and understand waiver types at least. But that just kind of gives a picture of how they might look slightly differently if you're looking in one data system versus the other, especially for different years. And then one other piece I just want to highlight is retroactive eligibility or retroactive coverage. So I just draw your attention to the top piece first, otherwise it'll get confusing. So the top arrow, I think we get a picture of, if you're thinking of private insurance, it's kind of like, okay, I got enrolled in insurance, and then I had an office visit or some type of ambulatory care visit, and then I had an emergency department visit, and those got covered. And so if a researcher is looking at me, I was enrolled, I had those services, and the researcher can see those services and understands that I was enrolled, and so it's very straightforward. That means if I'm disenrolled, that could be an issue of limiting my access, and maybe I had to forego some of those services. So if I'm talking about a lower income population, that kind of thing, the researcher is going to have to think, okay, how do we handle people who are disenrolled? The retroactive eligibility issue complicates this because core Medicaid, really what that does is core Medicaid actually will include the idea that, you know, if somebody comes in for a service and they're eligible, they can be covered 3 months prior. So anything that was picked up prior can then be billed for under Medicaid. So in this case, a person comes in for an emergency department visit or some type of acute use. The healthcare system identifies them as eligible, and they are able to get enrolled 3 months back. So anything that might have happened in that 3 months. So maybe they had an unpaid visit. Maybe they didn't have anything. We don't know necessarily, but what triggered the enrollment was not just an enrollment process. What triggered the enrollment was a utilization. So now if a researcher is trying to think about, well, I know what to do with enrolled people and I know what to look out for with disenrolled people, the retroactive eligibility possibility adds in an additional complication. Because now we need to say, well, if a person's not enrolled, maybe they had to forego care, maybe that's an access issue, that kind of thing. And also if I'm trying to identify what conditions that person has or any of the other information that might be on the claims, I know I'm just going to have a less complete picture if that person's disenrolled than if they were enrolled the whole time. But when retroactive coverage is a possibility, what that could mean is that actually having that healthcare need is what led to being enrolled, which the causal pathway is kind of backward in that sense. And so now how exactly I handle enrolled people versus disenrolled people changes a little bit depending on the assumptions I make about the pathway that leads to somebody being enrolled, pathway that leads to somebody being having utilization and the information that's derived from those claims. And I would just say that there's no real flag, there's no indicator that's going to really show you, this person was enrolled retroactively. So typically what you're doing is maybe if this is relevant to you, you may look for, okay, did they have some acute use in the 3rd month of enrollment or something like that, to kind of look for signals of it. But there's no kind of guaranteed signal. So we've run into it in a number of different projects, and it just exists. So it's just another consideration. And I would note that retroactive eligibility is subject to waivers. So I mentioned waivers, but Iowa and several other states, I'm just listing Iowa because there was an example that I found with Iowa, but there are a lot of states that have either eliminated or limited or changed the 3-month retroactive eligibility period. MacPac has a good report in 2019 on this. But basically imagine a state where instead of 3 months of retroactive coverage, you get 1 month or 0 months. Those kinds of things. That's another way that waivers can be used. And the last thing to get into, and we're over a little bit, but I should be done soon. Last thing to get into, I believe, is managed care. So managed care, to set the stage, under fee for service, what happens is a service is provided, the claim is submitted for that service to, say, a state Medicaid office, or in Medicare, a service is provided, a claim is submitted to Medicare. Now it's through various contractors, but it's submitting the claim to Medicare. So that claim form, which is basically a bill, it's submitted. There's some added information to inform payment, and then there's some processing, adjudication, and so on. What that means is that there's, under fee for service, there's kind of a fairly direct link between the services that are provided, the services that are billed for, and then the payment process and the resulting administrative data. What managed care does is it adds at least a middleman, but also some additional processing. So state plan amendments, including 1932A, and waivers. So I mentioned waivers, both 1915 A and B and Section 115 waivers have allowed states to implement managed care programs. Could be part of the state, could be statewide, could be certain, or it could be all aid categories. In this case, usually what's happening is the managed care organization is the one administering the initial steps of the program when claims might come in. So a provider may still bill on a fee-for-service basis, but they would be doing it with a managed care organization. So you might say like a private insurer, for instance, might be administering one or more managed care plans under Medicaid for the Medicaid program, in the same way that managed care organizations do it for Medicare Part C. What those managed care organizations do is they provide data on what we call encounters to the Medicaid program. Now, the encounter data, again, it kind of severs the direct kind of link that we would see in a fee for service, where you've got a service, a bill, the bill goes kind of straight to the program, and we get a resulting claim line in the data. This is a little different, where we've got a managed care organization has been billed by a provider, but then they don't just pass along that bill to the Medicaid program. They provide encounter data to state Medicaid. Now, in Medicare, if you're familiar with it, Medicare Parts A and B are under kind of the regular Medicare fee-for-service data, and then Part C is what we call encounter data in Medicare. But those are different data sources on the Medicare side. In Medicaid, you got claims and encounters all added in. And there may be some differing issues of data quality, and I would just suggest that we probably don't know a whole lot. I would say that when we have tried to look into it, I'm not necessarily overly concerned, but that's an editorialization. So it's just something to kind of pay attention to, that managed care has added some processing, some pre-processing before things go into the data system that fee-for-service doesn't. And so they're just processed a little differently. And to the degree that you think that processing may result in slightly different things in the data that are artifacts of the processing as opposed to what's really happening, it's something to pay attention to. We got a couple of different kinds. I would just emphasize the risk-based managed care as the primary one. The primary care case management does exist, where PCPs receive case management fees, but they're still reimbursed on a fee-for-service basis. But the risk-based is like what you'd be expecting in managed care, where you've got a fixed per member per month type fee in kind of a capitation setup, and it assumes either partial or full risk, partial or full financial risk related to the costs of caring for that person versus the per member per month fee. And they may be comprehensive or they may be non-comprehensive, so you may have behavioral health. If you look across things, managed care organizations are by far the majority. And even when they're not, they may be mixed with others. So you may have managed care organizations and the primary care case management in the same state. If you look at both that combination of states, that's almost all states. There's only a handful of states that don't offer MCOs. And the other thing I would just say is that when comprehensive MCOs are used, as opposed to just primary care case management, they are really the norm for beneficiaries. So in other words, when you've got MCOs there, which since they're in most states, that also means that most of what's happening in that state Medicaid program is managed care. And that means that by and large, if you're talking about Medicaid, did I say Medicare? If you're looking at Medicaid, you're probably looking at Medicaid managed care in a lot of cases. And so instead of claims, you'll be looking at encounter records. And the expansion. So we've talked, I'm sure you've heard a lot about expansion, but and you may have heard 138 versus 133. It's because of a modified adjusted gross income difference allowed on 5%. So in law it's 133, but 138 is allowed. Adults typically without dependents or without dependent children. States are not required to expand it. Pretty much same, similar aim at a fairly comprehensive benefit package. You got some changes in payment rates. I guess one thing that is of note is that the ACA also creates CMMI, or the Center for Medicare and Medicaid Innovation, which does a lot of payment and service delivery models changes and so on. And a lot of pilot programs and things. My teeth were cut on like a Medicaid managed care, accountable care organization in Minnesota in particular. That was one model but there's a bunch of them. And so in the status of the expansion as of 2024, you got most states have adopted expansion. But it remains a state level variable at the very least. And again, it primarily adds, you're usually looking at categories of eligibility based on circumstances, needs, and so on, income levels. And so prior to the ACA, as we mentioned, we got all these different groups. So what the ACA really added was low income limits raised a little bit, as well as low income childless adults or adults without dependents being added. And so that's kind of the broader picture now. And I would just, out of this table, the only thing I would call out is immigrants or citizenship as an issue. I think it's something we don't always talk about, but you've got qualified non-citizens who, if you could think about like green card holders or that kind of thing. There may be waiting periods around that and so on. And I think that immigration and citizenship may be something that really interacts with or intersects with your groups of interest that sometimes we don't always talk about very much. So I would just highlight immigration or citizenship status as something to also pay attention to in the data as you're kind of fine-tuning your cohort, along with all the other groups, of course. Oh yeah, and the resources that are there. So again, those are in the slides.